Bismillahirrahmanirrahim. Today we are going to discuss congenital obstetric complications, means those problems that arise during pregnancy. There are a variety of maternal and fetal complications that can arise during pregnancy. Most of these are due to the physiological changes that occur during pregnancy. Although these problems are not dangerous to the mother, but they can be extremely troublesome and can affect the quality of life of a woman. Learning objectives of today's presentation. At the end of the presentation, students should be able to determine causes and management of minor complications of pregnancy, to understand differential diagnosis and management of abdominal pain in pregnancy, to understand problems due to abnormalities of the pelvic organs, and to understand the risk factors and management of thromboembolic disease in pregnancy. First of all, we will discuss the minor problems of pregnancy. Problems of pregnancy can be divided into a system-wise groups like musculoskeletal problems, gastrointestinal problems, varicose veins, and edema. Musculoskeletal problems. Most of these problems are due to the physiological changes and the effect of hormones and other changes that occur during pregnancy. Musculoskeletal problems include Beckick, symphysis pubis dysfunction, and carpal tunnel syndrome. First of all, we will talk about the Beckick. Beckick is one of the most common complaints that the woman have during pregnancy. Beckick is caused by hormone-induced laxity of the spinal ligaments due to the shifting of the center of gravity as the uterus grows and due to the additional weight gain. Although Beckick is also a common problem in women without pregnancy due to their posture, but it is mostly exaggerated during pregnancy. In order to prevent the begging, the woman should be advised to maintain proper posture, to avoid heavy weight lifting, avoid high heels, regular physiotherapy, and in case of severe begging, simple analgesics in the form of paracetamol can be given. Second is the symphysis fluid dysfunction. Symphysis fluid dysfunction causes excruciatingly pain, most common in the third trimester, although it can occur at any time during pregnancy. It is due to the looseness of the symphysis pubis joint, because of which the two halves of the pelvis bone rub on one another when walking or moving. The condition mostly improves after delivery, and the management is simple analgesics in the form of paracetamol. Third is carpal tunnel syndrome. Compression neuropathies occur during pregnancy due to edema of the soft tissue, and carpal tunnel syndrome is one of the common of the neuropathies, in which the median nerve is most probably affected, where it passes through the carpal tunnel. It causes the numbness, weakness, and tingling of the thumb and forefinger, and mostly the pain is severe at night when the hand is immobilized. Treatment is simple analgesic and splinting of the affected hand, but the curative treatment is only after delivery of the baby. Second is the gastrointestinal problems. There are multiple of the gastrointestinal problems that occur during pregnancy, and most of these are due to the effect of the progesterone on the smooth muscles of the GIT tract. These include hyperemesis gravidarum, obstetric cholestasis, gastroesophageal reflux, constipation, and hemorrhoids. We will discuss in detail about hyperemesis gravidarum and obstetric cholestasis because these two are the problems that can need treatment. Hyperemesis gravidarum. Nausea and vomiting in pregnancy are extremely common and affect about 70 to 80% of the pregnant population. But these symptoms are mild and mostly improve after 3 months of the pregnancy. However, hyperemesis gravidarum is a severe and tractable form of nausea and vomiting that affect about 2% of the pregnancies. It causes imbalances of fluid and electrolytes, disturbs the nutritional intake and metabolism, and increase the risk of preterm birth and low birth weight babies. Treatment include fluid replacement. If needed, fluids can be given intravenously, thiamine supplementation, antiemetic such as phenothiazines, and in severe cases, corticosteroids may be effective. Obstetric cholestasis. It presents in the second half of pregnancy with pruritus and abnormal liver function tests, neither of which has an alternative cause, and both of which resolve after birth. The fetal risk of obstetric cholestasis are spontaneous preterm birth, iatrogenic preterm birth, and unexplained fetal death after 37 weeks. There is no specific treatment of obstetric cholestasis, but the symptoms improve with orthodeoxycholic acid. Vitamin K should be given after 36 weeks of pregnancy to prevent the risk of hemorrhage, and anti-allergy should be given in order to improve pruritus. The pruritus associated with obstetric cholestasis has a specific characteristic. It is worse at night and more it on the palms and soles of the feet. And for the criteria of obstetric cholestasis, these symptoms should be improved probably within 10 days of delivery. The other problems related to gastrointestinal tract, such as constipation, hemorrhoids, and gastroesophageal reflux, are probably due to the hormonal changes during pregnancy. And in these cases, mostly no specific treatment is given, but the dietary changes should be advised. Diet should be taken in the form of small frequent meals. The patient should be advised to keep proper position in order to prevent gastroesophageal reflux. Plenty of fluid should be taken in order to prevent constipation. In most severe cases, laxatives should be given to relieve the symptom of constipation. Now, the problems due to abnormalities of the pelvic organs. If there is any problem in the pelvic organ, it can cause problem to the mother or the baby depending on the condition. First of all, fibroids. Fibroids are Compact masses of smooth muscle that lie in the cavity of the uterus, within the uterine muscle, or outside the surface of the uterus. Mostly the fibroids lie during pregnancy due to the increase in the size of the multi-gravid uterus. Fibroids may cause problems in pregnancy like red degeneration of fibroid, torsion of the subserous fibroid, problems in the descent of presenting part, and malpresentation. Red degeneration of fibroid is one of the most common complications that occur during pregnancy. As the fibroid grows, fibroid may become ischemic, which manifests clinically as acute pain associated with vomiting and tenderness for the fibroid. The red degeneration of fibroid mostly requires treatment in the hospital in the form of potential analgesic and dehydration. The patient should be given opiate analgesics and intravenous fluid. A subserous proliferated fibroid may persist as the pregnancy advances and also present as acute abdominal pain. If the fibroid is located in the lower uterine segment or in the cervix, it may cause descent in the it may cause problem in the descent of the baby, and the patient may end up in cesarean section. Malpresentation. Depending on the location of the fibroid, it may distort the structure of the uterine cavity, and the baby may present in mal- may present in the form of breech or transverse line. Second is the congenital uterine anomalies. Sometimes during the development of the genital tract, some uterine abnormalities are developed. These may be in the form of uterine septum, a subseparate uterus, or in the form of bicolumnate uterus. Congenital uterine anomalies can cause miscarriage, preterm labor, preterm premature rupture of membranes, abnormal presentation, and higher cesarean section rate. Ovarian cyst in pregnancy. Ovarian cyst can be pathological such as benign teratomas and serous cyst adenomas, or it can be physiological such as the large corpus luteum cyst. Complications of the ovarian cyst include torsion of the ovarian cyst, hemorrhage or rupture of the ovarian cyst, miscarriage, and preterm labor. If there is torsion of the ovarian cyst, the patient may present with acute abdominal pain and may need emergency laparotomy. Treatment of the ovarian cyst during pregnancy include if the cyst is asymptomatic but only accidentally diagnosed, it should be followed by clinical and ultrasound examination. Large cyst may require surgery. Surgery is usually postponed until the late second or early third trimester. But in the case of rupture or torsion, if the patient presents with acute abdominal pain, the patient may need emergency laparotomy irrespective of the duration of the gestation. Urinary tract infection. Urinary tract infections are common in pregnancy. If this is untreated, it may progress to pyelonephritis, and it may result in low birth weight and preterm delivery. The predisposing factors for UTI are history of recurrent cystitis, urinary tract abnormalities, diabetes mellitus, and bladder emptying problems. Investigation required for the confirmation of urinary tract infection are full blood count, urine routine examination, urine culture and sensitivity, and renal ultrasound in case of recurrent UTI. Treatment of urinary tract infection include plenty of clear fluids, analgesics, antibiotics either oral or IV depending on the severity of the infection. If urinary tract infection is not treated properly in time, it may lead to pyelonephritis and in result of infection, patient may go into preterm labor. Abdominal pain in pregnancy. Abdominal pain is one of the commonest disorders of pregnancy that can be caused by multiple reasons. The cause may be pregnancy related, it may not be related to pregnancy, and it can be due to any medical condition. The list of the causes of abdominal pain is given in the table 6.1 on page 84 in 10 Teachers of Obstetrics. Kindly read the causes from there. Some of the causes we previously discussed in this lecture that abdominal pain can be due to degeneration of fibroids, like it may be due to ovarian cyst. If it is rupture or torsion, it can be due to miscarriage. It can be due to placental abruption or ectopic pregnancy. Nutrient can also cause abdominal pain. So there are multiple reasons of abdominal pain. So from detailed history and examination, we can reach the diagnosis of abdominal pain in pregnancy. Venous thromboembolism. Venous thromboembolism is the most common cause of direct maternal death in United Kingdom. Pregnancy is associated with a 6 to 10-fold increase in the risk of venous thromboembolism. Pregnancy is a hypercoagulable state because of an alteration in the thrombotic and fibrinolytic systems. There is an increase in the clotting factors and a reduction in the protein S and antithrombin 3 concentration. Due to these changes, there is increased chances of thrombosis during pregnancy. The risk factors for venous thromboembolism can be divided into pre-existing and those developed during pregnancy. The pre-existing risk factors are maternal age more than 35 years, thrombophilia, obesity, previous history of thromboembolism, smoking, and malignancy. The risk factors specific to pregnancy are multiple gestations, preeclampsia, grain multivariety, cesarean section, especially if done in emergency, and prolonged bed rest. How venous thromboembolism can be diagnosed. The clinical diagnosis of venous thromboembolism is unreliable. For women who are suspected should be investigated. The commonest symptoms of venous thrombosis is pain in the calf muscle with varying degrees of redness and swelling. However, swelling of legs is common in pregnancy. So if this swelling, pain, and tenderness is unilateral, it should be an alarming sign for venous thromboembolism. Investigation which can be done for the diagnosis of venous thromboembolism include compression ultrasound. This ultrasound is a high sensitivity and specificity in diagnosis of proximal thrombosis in non-pregnant women and should be the first investigation used in the patient with suspected DVT. If pulmonary embolism is suspected in ECG, X-ray chest and ABG should be done to exclude other respiratory diagnoses. If all the tests are normal, but there is high clinical suspicion of pulmonary embolism, a ventilation perfusion scan should be performed, or CT pulmonary angiogram should be done. Nowadays, D-dimers are commonly used as a screening test for thromboembolic disease in non-pregnant women in whom it has a high negative predictive value. But in pregnancy, due to the physiological changes, the D-dimers cannot be as reliable as in non-pregnant women. Treatment of venous thromboembolism. Low molecular weight heparin are the treatment of choice, and these are as effective and safe as unfractionated heparin. Low molecular weight heparin are easy to administer, and women are taught to inject themselves and can continue on this treatment for the duration of their pregnancy. Following delivery, women can choose to convert to warfarin. Initially, the ANA should be checked frequently to adjust the dose of warfarin. Graduated elastic stocking should be used for initial treatment of DVT and should be worn for at least 2 years following a DVT to prevent post-thrombotic syndrome. Prevention of venous thromboembolism in pregnancy and postpartum. The Royal College of Obstetricians and Gynecologists has recently updated guidelines on the prevention of thrombosis and embolism in pregnancy and the perfusion, and these are summarized in Figure 6.2 on page 87 in Obstetrics Patent Teachers. Kindly have a look on the figure for the antenatal assessment and management of venous thromboembolism during pregnancy.